So for the next 4 years, we already know that health spending is going to be flat in real terms. What this research shows is for the 2 years after that, health can expect another period where spending is flat, but quite possibly cut. After that, health spending is unlikely to return to its historic rate of growth, which was 4%, but is likely to grow at about half that rate for the long term. Health funding is going to be around half the rate of growth that the NHS has historically enjoyed. We will not be able to deliver the quality and access to healthcare that the population expects if healthcare is delivered in the same way that we've delivered it for the last 50 years. That means major transformations to the way that hospitals operate and almost certainly improving primary care and shifting services from hospitals into the community. There are two reasons to be optimistic about the NHS's ability to deliver productivity gains at a higher rate than the historic average. One is that there is substantial variation in the NHS that shows us that somewhere in the NHS, someone is almost certainly already delivering services in the way that we need services to be delivered in the future. So we can see that somewhere that it can be done. So part of the challenge is making that the norm rather than the exception. The other source for optimism is that there's actually substantial agreement about the sort of changes that need to be made in order to deliver sustained improvements. Rationalising hospital care, avoiding unnecessary admissions to care by providing much better quality care closer to people's home, using the skills and talents of our workforce in new ways. All of these things have huge agreement amongst healthcare professionals and those involved in the management of the health service. The challenge is to make that the norm. In a number of areas of the country at the moment, there are already lists being drawn up of low priority treatments where PCTs are questioning whether those should be available on the NHS. And those cover things like the number of IVF cycles that people may be able to have. Obviously, if the NHS can't deliver a sustained improvement in its productivity, then the range of services that might be subject to that debate about is this a low priority treatment and for who is it a low priority will become more and more common and extend into services that people would historically have seen as unarguably a service which is core to the NHS.